Okay, last one for today, gout. There are two forms of gout. We have primary and secondary. In both cases, the patient's uric acid levels are high. In primary gout, it comes with your body, meaning your body just metabolizes uric acid in a weird way, wherein your body makes so much of it, regardless of your diet or medications you're taking. In secondary gout, it's usually caused by diet or medications. Any question on the difference? Okay. Treatment, though, will be the same. Yes, sir. Yeah, primary, meaning it's not caused by your lifestyle or your medication. Your body just has a weird way of metabolizing uric acid, and your body makes a lot of it.
So that was caused by dieting or starvation?
The
Primary.
secondary.
It says primary.
Yes. It can be affected by diet, of course.
That's what it says in the book. So what do you? It says secondary is caused by self, genetic and acquired processes.
Again, the secondary is caused by your habits, your lifestyle, meaning you eat a lot of meat or shellfish, purines. Where exactly?
It's next under patho, the secondary.
Where is primary?
Right here, primary.
No, this is hyperuricemia, not gout. Sorry. Is that the same?
Oh, it's caused by
yeah. Hyperuricemia is not the same as gout. So with gout, primary gout, you have what again? It's in your body, meaning your body metabolizes uric acid in a strange way. Okay. So what happens in gout? Number one complaint by the patient is pain, severe pain. And with repeated attacks, the first attack, by the way, is usually going to affect the big toe, the left or right or both big toes, caused by the accumulation of uric acid crystals. They usually accumulate in the periphery. And unfortunately, the most periphery is the great toe. So a patient will have severe pain and swelling on that toe. So their number one only concern is the pain. They cannot walk, they cannot wear shoes, they cannot put socks on. Even a thin sheet of blanket will be painful enough. So alcohol, anything that has high purine, let's say alcohol, chocolate, or red meat, say you have I remember my mechanic is Muslim, and after Ramadan, I guess you party. Is that true? You have no? Or am I talking about a different?
Yeah.
Yeah. So he said, he eats extra meat, and then whenever I see him, he says, he's not here, he's not working today. And so the shop is closed. And he opens, I asked him, what happened? Yeah, he's still, limping, and then shows me his toes. After a party. So let's go straight to, so you know the triggers. So therefore, what do you think will be the teaching for the diet? Okay, avoid the following as mentioned here. So let's go now to other triggers. So we've got drugs, especially diuretics. Thiazide, diuretics in particular. Aspirin can also be a trigger. MSG can also be a trigger. Manifestations, as I mentioned, it's the tophi. This is now the inflammation of the great toe. I won't test the stages. Let's go to the manifestations, of course, is the inflammatory period, very painful episodes. And here are other triggers in addition to what's already been mentioned. Management is both diet modification and medication. Now let's look at each drug and when they are used. If the patient has an acute attack, let's say Mr. Khan, my mechanic, during an acute attack, he will be prescribed colchicine. Colchicine is only used for maybe maximum a few days to maybe 2 weeks at the maximum, because the drug is very nephrotoxic. It can damage your kidneys. So it's not used long term. It's only used when? Acute attacks only. So when you're having severe painful, swollen toes, okay, or sometimes in other joints in the body as well, but usually the toes, you're prescribed colchicine. For how long?
2 weeks.
Maximum. Okay, so only a few days to until your symptoms disappear. As soon as the symptoms disappear, stop the colchicine. Okay, so the sooner you stop, the better for your kidneys. Yes, Lily? Yes, it was also prescribed in pericarditis. Usually in recurrent or chronic pericarditis. The NSAID, only in indomethacin though, is usually prescribed. Somehow it's the only NSAID that will work for gout, or patient will be placed on steroids. So a combination of what again? Colchicine, indomethacin, or steroid. Now for long-term, meaning if you have, let's say, primary gout, the patient will be placed on xanthine oxidase inhibitor. The drug name is allopurinol. This one is for maintenance. Okay, so this can be taken daily. But for acute episodes, you think allopurinol will still work? It will not work during acute episodes. Because remember, the patient's been taking it daily. So when they have an acute episode, does it make sense taking the same thing? No, you stop it and take colchicine instead until the symptoms, the acute symptoms subside, patient's better, then they go back to allopurinol. Any question? For long-term management, let's say the patient has repeated attacks of gout, making the disease unmanageable, or let's say they can't keep their job anymore, they'll be put on. Remember this drug, anakinra?
Yeah.
This was used also in what? Rheumatoid arthritis as well. And other immunomodulators like an interleukin-1 receptor agonist. These are now injections, just like anakinra. And lifestyle modifications, of course, is avoiding the red meats, shellfish, alcohol. Probenecid may also be prescribed, but it's not really very popular. We had steroids already earlier. All right, and here's your nursing responsibilities and client teaching for the drugs mentioned in the paragraphs. So colchicine, probenecid, allopurinol. Any questions on gout?